Good evening, everybody. In today's lecture, let us try to learn about the basic pharmacology of arsenic trioxide, nitrosoureas, and retinoids. In previous classes, we have discussed about hydroxyurea. So I think you have gone through those lectures and all. So this is the 20th day of our 1 month basic oncology course. So let's begin our session with arsenic trioxide. Okay. So arsenic trioxide is a very important drug that clinical pharmacists should try to understand. Let me tell you a few important points initially. Before understanding about the pharmacology, we'll discuss few important points. Always you have to remember. See, first thing, arsenic. Arsenic is a basic element which is present on the earth crust, and this element is an inorganic compound, inorganic element, and this element is very toxic. Very toxic. You have to remember this. Arsenic can cause many toxic effects. First point, it is a toxic element. But few arsenic compounds are therapeutically they are used. Therapeutically, they have certain uses in the hospital, and in that uses, arsenic trioxide, As2O3. This compound is very commonly used in hospital, especially for relapsed APL, relapsed APL, acute prolymphocytic leukemia, acute prolymphocytic leukemia. Okay, so one thing, arsenic is a element which is very toxic in the it is very toxic. Okay, and despite of its toxicity, sometimes arsenic trioxide is used in hospital, particularly for relapsed APL. It is used for relapsed APL. Okay, so this point we have to remember. Now you see, I would like to tell you the mechanism of action of arsenic trioxide. Always remember, there is no specific mechanism, but it has few mechanisms. It has no single mechanism, but it is showing its activity through different mechanisms. In that, the first one, I think 5 to 6 mechanisms it has. Always remember. See, first mechanism is this arsenic trioxide. It produces or it generates reactive oxygen species in the body, in the cell. And what this reactive oxygen species does, it will try to kill or it will damage the APL cell. It damages APL cell. Okay, acute prolymphocytic cells are degraded by the generation of reactive oxygen species. This is first simple mechanism. I'll not go in detail with the molecular level concepts. Okay, just try to understand. It generates reactive oxygen species and it damages the proliferated acute prolymphocytic cell. Okay. Next, along with this reactive oxygen species, it also produces cytochrome C. Cytochrome, cytochrome C, very important protein. What the cytochrome C does, this cytochrome C is very important protein. It helps or it aggravates or it causes apoptosis. Apoptosis. So, what cytochrome C does? Cytochrome C induces the cell death. Cell death. So the prolymphocytic, all prolymphocytic cells, whatever patient has, those cells were degraded due to this cytochrome C protein. This is the second mechanism. It is generating ROS. It is also producing cytochrome C. And next mechanism, if you see very important mechanism. It is this arsenic trioxide. It helps in differentiation of APL prolymphocytic cells. Okay, it helps in differentiation of prolymphocytic cells. See, prolymphocytic cells are undifferentiated. In previous class already I told what is proliferation and what is differentiation. Proliferation is nothing but rapid production of new cells which are unmatured. Rapid production of cells is called proliferation, and differentiation is nothing but maturation of the cells. The premature cells, what they will do, they will mature, and once the cell is matured, what happens, it will complete its lifespan and it will die. Unless the cell is differentiated, it will not die. So proliferated cells will not die, whereas differentiated cells will die. So here Arsenic trioxide, what it is doing, it is helping in differentiation of the cells, and further after its differentiation, it will complete its self life cycle and it will die. Cell will die. So through that way, this arsenic trioxide is helping in uh, acute prolymphocytic leukemia. And fourth mechanism is very, very important mechanism. See, in acute prolymphocytic leukemia, in this APL, patients PML gene and RAR gene, both the genes are they are fused. And due to the fusion of this PML and RAR gene, it produces a protein which is called APL RAR proteins. PML-RAR, not APL, it is PML-RAR alpha proteins. So these proteins, what they do, these proteins will again cause formation of APL. Okay. So APL formation is caused due to the production of the proteins which are PML and RAR proteins, and this production of proteins is seen in patients whose gene fusion is occurred due to PML and RAR. So here, the arsenic trioxide, what it does, arsenic trioxide will degrade these proteins. And with that, what happens? Due to the degradation of these proteins, it will stop formation of APL. Simple. This is very, very important mechanism. And final, last mechanism of arsenic trioxide is arsenic trioxide will inhibit angiogenesis, angiogenesis, and it inhibits IKB kinase enzyme. Very, very important mechanism. This is arsenic trioxide. What it does, it inhibits IKB kinase enzyme, which is simply called as IKK. IKK enzyme is inhibited by arsenic trioxide. And when this enzyme is inhibited, let me make you very clear here. The final most mechanism is very important. You have to concentrate. Okay. What was the final most mechanism of arsenic trioxide? Arsenic trioxide will inhibit IKK. Now you see it's very interesting and very easy. The fifth mechanism, it inhibits IKK. What is IKK? It is the IKB kinase enzyme. Actually, what is the function of this IKB enzyme? This enzyme will activate nuclear factor kappa. Nuclear factor kappa B. We call it nuclear factor kappa B. Okay. These are the proteins which are activated by this IKB kinase enzyme. Okay. So these nuclear factor kappa B proteins, they will further help in cell survival. Cell survival. Okay. And this cell survival is helping for APL cells. APL cells. That's why if we inhibit this IKK, if we inhibit this IKB kinase enzyme, what happens? No NF kappa B proteins are synthesized and cell survival is stopped, and further it causes apoptosis. Apoptosis. Simple. So these are 5 different mechanisms of arsenic trioxide. Okay, just try to rewind the video and you can see. Okay, these are 5 different mechanisms. So I'll try to make you very easy. See, as I told, the first mechanism, it helps in production of reactive oxygen species, right? This reactive oxygen species, what it does, they will directly cause apoptosis. Number one, first mechanism. Number two, it promotes cytochrome C. It helps in production of cytochrome C. What is cytochrome C does? Cytochrome C further activates procaspase 9. Procaspase 9 again activates procaspase 3. Procaspase 3 again activates caspase 3, and this further causes apoptosis. Apoptosis. So finally, cytochrome C is also helping in apoptosis, in the programmed cell death of APL cells. Okay. So this is second mechanism. Second mechanism is production of or activation of cytochrome C. And again, what I told it inhibits IKK enzyme. Okay. IKK is called IKB kinase. So IKB kinase enzyme, what it does, it activates nuclear factor kappa B, and further it helps in cell survival. If this enzyme is inhibited, what will happen? Further cell survival will be decreased. Okay. So this is another mechanism. And again, I told, see, PML and RAR alpha proteins are very important. So this arsenic trioxide, what it is doing, it is degrading the PML RAR alpha, and with that, it causes differentiation, and further it causes the cell death due to its completion of lifespan. Okay, once cell is differentiated, it will die. Okay, so this is the mechanism, different types of mechanisms of arsenic trioxide. I think you all understood. Simple. Arsenic trioxide. Arsenic trioxide is the toxic molecule. It is a toxic molecule which has different mechanisms in the body, and particularly it is used for APL. Remember APL, acute prolymphocytic leukemia. Okay, that's it. Now we'll see the pharmacokinetics of arsenic trioxide. Always remember, arsenic trioxide has good oral bioavailability, but it is not used orally. Not used orally. Okay, one point you have to remember. And it is used only through IV administration. And the IV administration is given for 2 hours daily. It is given. It is infused for 2 hours daily, and the doses is 0.15 mg per kg per day, and it is given till 60 days. Okay, up to 60 days till total remission is seen. Total signs and symptoms of the patient was disappeared. Till that it is used. Okay, arsenic trioxide. Remember, it is not used orally, it is used in intravenous infusion, and it is infused for 2 hours daily, and it is given till 60 days, and the dose is 0.15 mg per kg per day. Clear? And it is distributed in all parts of the body. It is metabolized by enzymatic methylation. Cytochrome P450 enzymes will cause methylation, and the methylated compound will be rapidly excreted through urine. Okay, cytochrome P450 enzymes causes methylation. The methylated compounds will excrete through urine. Okay, and remember, up to 20% of compound which is excreted is in unchanged form. Unchanged form. Okay, 80% of the arsenic trioxide is metabolized by methylation, and remaining 20% is not metabolized. It is excreted as it is from urine. Okay, so only 20% is excreted through urine. That's why if patient is having hepatic failure or renal failure, in that cases doses are need not it is not needed to uh, reduce. Okay, so this point you have to remember about arsenic trioxide. And adverse effects are very, very important for arsenic trioxide. ATO is also known as arsenic trioxide or arsenic trioxide. Arsenic trioxide is also called ATO. See, most of the time, the normal doses are well tolerated by the patients. Okay, in higher doses, it is very toxic. Already we know. See, sometimes when overdoses are given, and in normal doses also, some side effects are seen with arsenic trioxide. It causes hyperglycemia. Very, very important. Arsenic arsenic trioxide will cause hyperglycemia, and arsenic trioxide will induce cytochrome P450 enzymes. It will induce cytochrome P450 enzymes, same like phenytoin, phenobarbital. Okay, we have enzyme inducers we have discussed in previous classes. Crab GPS. Okay, carbamazepine, alcohol, rifampicin, all those drugs we have seen. So it induces cytochrome P450 enzymes. Sometimes fatigue, dysesthesia, abnormal sensation of the nerves. Okay, abnormal sensations can be seen, and sometimes headache can be seen. So these are common adverse effects. Hyperglycemia, you have to remember, hyperglycemia, hepatic enzyme elevations, because most of the time enzymes are elevated because it is an enzyme inducer. Fatigue, dysesthesia, and light headache. These are common adverse effects. And few adverse effects are leukocytic maturation can be seen. Leukocytic maturation syndrome, we call it. Leukocytic maturation syndrome. And this type of syndrome is also seen with tretinoin. Okay, tretinoin is also called atra. Okay, atra is tretinoin. This is the vitamin A related compound, vitamin N analog. We'll discuss in now next slides. I'll explain about retinoids. It is a retinoid. So retinoid atra. In atra also it causes leukocyte maturation syndrome. So it is very common with arsenic trioxide as well as with tretinoin. Okay, and in that it causes pulmonary distress. Very, very important. Pulmonary distress, pulmonary effusion, and mental status changes. These are all things are seen with atra as well as with arsenic trioxide. Okay, oxygen corticosteroids and temporary discontinuation lead to full reversal of this syndrome. Okay, so oxygen therapy and corticosteroid therapy can be given if patient is having leukocyte maturation syndrome. Okay, so that's it about arsenic trioxide. Now we'll discuss about retinoids. Okay, retinoids are vitamin A related analogs. These are vitamin A analogs. Always remember, retinoids are the compounds which are very similar to retinol. Okay, so these are vitamin A related compounds. Most of the time, vitamin D associated compounds, vitamin A associated compounds, all these drugs are sometimes used in cancer. They are used in cancer as chemotherapy agents. In that, tretinoin, remember, tretinoin is very, very important drug. Okay, so in retinoids, actually, these retinoids, vitamin A associated compounds, they are widely used in acne. Actually, they are used in acne, but in cancer also they are used. Now you see, I'll try to make you understand about this retinoids. First point, retinoids are vitamin A related analogs. Okay, they are vitamin A analogs. Retinoids are vitamin A analogs. Vitamin A analogs. They are used in cancer as chemotherapy. Okay, they are used in dermal related disorders in few conditions like acne vulgaris. In acne, they are used. This is another important point. And always remember, these retinoids are very teratogenic. Teratogenic. If anybody is applying this retinol on their skin, always remember they should not conceive. Not conceive. Very important point. Females who are using retinoids should never conceive when they are using retinoids. This is important point. Being clinical pharmacist, we have to remember. Now you see, actually, in retinoids we have so many examples. In that we have three generations. Examples, I'll just try to explain you about the examples. See, in that three generations, yeah. See here we have first generation. You can zoom and you can see first generation retinoids. In that we have retinol. We have tretinoin. Very important drug. And we have isotretinoin, isotretinoin, and we have alitretinoin, alitretinoin. So these four drugs, retinol, tretinoin, isotretinoin, and alitretinoin, these are first generation retinoids. These are first generation retinoids: retinol, tretinoin, isotretinoin, and alitretinoin. Okay, tretinoin is also called all trans retinoic acid. That's why it is called ATRA, ATRA. Just previously I told about arsenic trioxide. Arsenic trioxide causes it causes leukocyte maturation syndrome. In that, ATRA also causes the same syndrome. That's why just now I told you. Okay, ATRA means tretinoin. Tretinoin is the ATRA is the other name for tretinoin. Okay. Anyways, now you see first generation four compounds we have discussed. Now second generation retinoids. In that we have etretinate, etretinate, acitretin, acitretin, and yeah, these two are the examples of second generation retinoids. And third generation retinoids, we have adapalene, we have bexarotene, and tazarotene. So these are third generation retinoids. Now you see, everybody should concentrate here. Always everybody should concentrate. Mechanism of action, I'll explain you. Before that, see, all retinoids will act on two types of receptors. They'll act on two types of receptors. We have nuclear gene expression receptors. These are nuclear receptors. We call them as nuclear gene receptors or nuclear gene expression receptors. They will express the genes. That's why they are called nuclear gene expression receptors. They'll act on these nuclear receptors. And in nuclear receptors, we have two types. Number one is a retinoic acid receptor RAR, and the second one is retinoic X receptor. So we have two types of nuclear gene expression receptors on which retinoids will act. Retinoids will act on these two types of receptors. Number one is retinoic acid receptor, and number two is retinoic X receptor. Okay. See, retinoic acid receptor is very important in differentiation of cell, and it helps in cell proliferation. Mainly, it helps in differentiation of cell. So, differentiation of cell activity is required in which disease condition? It is very well. It is required in acute pro-lymphocytic leukemia. In pro-lymphocytic leukemia, the differentiation of the cells were not seen. That's why the drugs which are active, the drugs which will act on these receptor, which will bind and they will increase the action of RAR receptor, those drugs are mainly used in acute pro-lymphocytic leukemia. And the examples of the drugs which will act on RAR receptor are tretinoin, adapalene, and tazorotine, tazorotine. So these three drugs, retinoin, adapalene, and tazorotine, these three drugs will bind on RAR receptor and it will increase the activity of RAR receptor, and for that it will increase differentiation of the cells. That's why it is used in acute prolymphocytic leukemia. And next receptor is retinoic X receptor or retinol X receptor, or simply it is called RXR. This receptor is very important in inducing, it induces apoptosis. That means it helps in just destruction of the abnormal cells. Wherever abnormal cells are produced, in that RXR receptor is activated, and further it will cause apoptosis. Okay, so here the RXR receptor activators are bexarotene, bexarotene, alitretinoin, tretinoin. These two drugs, bexarotene and alitretinoin, they will activate RXR receptor, and with that it induces apoptosis. That's why these two drugs, the drugs which will activate RXR receptors, what they do? They will be used in CTCL, cutaneous T cell leukemia. Okay, this one we have discussed in previous classes, and it is also useful for sarcoma. Okay, so retinoids or the vitamin E associated compounds, they'll act on these two receptors, RAR and RXR. Now you just see the mechanism very clearly in the image. It is very clear. See, these retinoids, actually in RAR and RXR we have sub receptors also, RAR alpha, RAR beta, and RAR gamma. Okay, in same way XRX receptor also we have alpha, beta, and gamma isoforms of nuclear receptors. Okay, the retinoids will act on these receptors and they will increase the activity of these receptors. Okay, few receptor activation causes differentiation, proliferation, apoptosis, and it also helps in immune modulation. All these things we have already discussed. I think you understood. Okay, retinoids will act on these receptors. When RAR receptor is activated, it causes differentiation of cell. When RXR is activated, it will cause cell apoptosis. Simple. Okay, now I think this point is clear. To mechanism of retinoids is clear. And one more very, very important point, for tretinoin, there is another mechanism for tretinoin particularly. It has, see, just now I told PML-RAR alpha is the protein. Actually, this is the protein which is produced due to the infusion. It is produced by the infusion. It is produced by the fusion of. It is produced by the fusion of PML and RAR gene, right? When this PML RAR gene is fused, it will help in, I mean, it will induce acute prolymphocytic leukemia. Okay, acute prolymphocytic leukemia is mainly induced due to the infusion of PML and RAR and due to the production of these PML RAR proteins. So here tretinoin, what it does, tretinoin will it will degrade these PML RAR proteins. Okay, same like arsenic trioxide. Arsenic trioxide also has same action. Arsenic arsenic trioxide also degrades the fusion of PML RAR alpha, and tretinoin also degrades the fusion of PML RAR alpha, and through that this degradation, it is very helpful in APL, acute prolymphocytic leukemia. This is important mechanism for tretinoin. Okay, I think mechanism is clear for you all. Now see, arsenic arsenic is also toxic, and retinoids are also toxic. Remember, vitamin A analogs are not they are not easy compounds. They are not safe. They are very toxic. Remember, okay. Now, the adverse effects of retinoic acid or retinoids. Always remember with this mnemonic. This is a mnemonic. The mnemonic for toxicity or adverse effects which is associated with the retinoids. See, dry noses causes reduced hair, lipids, and hypothyroidism. Dry nose causes reduced hair, lipids, hypothyroidism, inflammatory muscles, pseudotumors, and mood disorder. Dry nose will cause all this. Okay. So with this mnemonic, remember, it causes drying of skin and mucous membranes, dry skin, dry mouth, xerostomia, and with that it causes nasal bleed. Okay, nose will bleed. If the mucous membranes in the nasal cavity is dried up, it will cause bleeding. So it will cause nosebleed. It causes conjunctivitis. It causes night vision reduction, night blindness. It causes hair loss, alopecia. It causes lipid and liver enzyme elevation. Okay, serum lipids and liver enzymes will be elevated in the body. It causes hypothyroidism, very important. Inflammatory bowel disease, musculoskeletal pain, and pseudotumor cerebri. This is the tumor of brain. Okay, brain tumor. Actually, pseudo brain tumors like symptoms can be seen, and mood disorders, mood alterations can be seen with retinoids. So these are different adverse effects which are associated with retinoids. And always remember, retinoids, tretinoin, and all vitamin A analogs should never be used in pregnancy. In pregnancy, these drugs, retinoids, should never be used. Okay, very, very important point. And if you see the pharmacokinetics, retinoids, especially retinoin, is used through oral administration, and the dose is 45 mg per meter square per day until 30 days. Maximum 90 days it can be given. And it is cleared by cytochrome P450 enzyme, same like arsenic trioxide. And the T half is less than 1 hour. So its T half is 1 hour. So its duration. Do you know how to calculate duration? Duration of action. Duration of action. So if its T half is 1 hour, so what will be the duration of action? Always remember the T half is multiplied with 5 hours, and five T half is multiplied with five times, and that becomes duration. So 1 into 5, 5 hours. So 5 hours will be its duration of action. And if the drug's TF is 3 hours, then its duration of action is 3 into 5. So 5 3 is 15. 15 hours will be the duration of action. Okay. Anyways, treatment with these retinoids, always remember, when retinoids are given along with enzyme inducers, cytochrome P450 enzyme inducers, the retinoids activity decreases. And when these retinoids are given with enzyme inhibitors, the toxicity of retinoids increases. Simple. Okay, so this point you have to remember, because retinoids are considered as narrotherapeutic drugs. One important point you have to remember. Next, we'll discuss about nitrosoureas. Nitrosoureas. In nitrosoureas, always remember carmustine, lomustine, very commonly used drugs. Along with this, semestine. This is not used in hospital because semestine causes renal damage, renal failure. It is having high probability of causing renal failure. That's why semestine is not used in hospital. So just forget this drug. We'll discuss about carmustine, lomustine. Both are very, very similar. And streptozocin is also nitrosoureas. Okay, these are four examples of nitrosoureas. And along with these few other drugs are also there. We'll not discuss. Okay, so we'll discuss with about carmustine. Always remember, carmustine is called 1,3-bis 2-chloroethyl nitrosourea. Here we have 2-chloro nitrosourea. This is the compound of nitrosourea. Okay, just see, this is the nitrosourea basic core molecule, and on this molecule, if two chlorines are added, chlorines with ethyl group, that is named as B bichloronitrosourea. Okay. Now, this carmustine. Before understanding about this carmustine, I would like to tell few important points about nitrosourea. See, nitrosoureas are mainly used in brain tumors. Brain tumors. Nitrosoureas are mainly used in brain tumors. One important point. Nitrosourea means what you have to remember? You have to remember brain tumors. Number two, nitrosoureas are very, very lipophilic. Lipophilic. They are having high lipophilic nature. They are highly lipophilic. That's why they can cross easily through blood-brain barrier. That's why they are used in brain tumors. Brain tumors. This is another important point. Okay, and these compounds are very unstable in aqueous solutions. They are unstable. Okay, and I told semestine can cause renal failure, that we already know. And see, these nitrosoureas, they are not only used in cancer chemotherapy. Nitrosoureas are carcinogenic carcinogenic and they are mutagenic. Mu- Mutagenic. They can cause carcinogenesis, secondary cancers, and they can also induce mutations in the body. So this is very, very important point you have to remember. Now, see, if you see the mechanism is very simple. All nitrosoureas will cause, they will like alkylation. So we have alkylating agents, right? Their mechanism is very similar to alkylating agents. alkylating agents, because what they will cause alkylation of the DNA alkylation occurs, and with that it causes DNA damage, or it stops the replication of DNA. That's why uh, these nitrosoureas are having similar mechanism like alkylating agents. Okay, anyway, that is now therapeutic uses. We'll see. If you see this nitrosoureas, in that carmustine particularly, carmustine is used intravenously over 1 to 2 hours, and it is used for every 6 weeks, and this is used particularly for brain tumors. Okay, number one. Number two, this carmustine, it is available as implant. An implantable carmustine wafer is available. Carmustine wafer. Wafer is a type of, it is like biscuits. Okay, so implantable carmustine wafers are used, and these implants are implanted in the brain for brain-related cancers, especially for glioblastoma. Okay, in glioblastoma, carmustine implants are used. Carmustine implants are, these are implantable wafers are formulated and they are placed in the brain. Okay. So carmustine means, always you have to remember, carmustine means they are biscuits. These biscuits are inserted in the brain. Biscuits are inserted in the brain. Always remember. And it is also available in IV form. Okay. And this carmustine and lomustine both are very, very commonly used for brain cancer. Brain cancer. Okay. So if you see the pharmacokinetics of carmustine, particularly carmustine is very unstable, as I told. Mostly all other nitrosoureas are very unstable, and it is given through IV route. If it is given through IV route, it disappears from the plasma highly. Immediately it will be metabolized, and its T half is 15 to 90 minutes. Okay, approximately 30 to 80% of the drug is uh, uh, appeared in the urine within 24 hours. Okay, as end products or metabolic end products. Okay, and the alkylating metabolites enter rapidly into the cerebrospinal fluid. See, when nitrosoureas are given, they are uh, metabolized into uh, this alkylating agent. Okay, alkylating agent. These alkylating agent type metabolites enter into brain, and in brain they will cause their action, anti-cancer action. Okay, that is 15 to 30% of this compound is entering into the brain. Okay, this is another important point about pharmacokinetics of carmustine. Now we'll discuss about streptozotocin or streptozotocin. Okay, streptozotocin. This is methyl nitrosourea. This moiety, it is attached with the two molecules of glucose. Always remember, streptozotocin is combined with the two molecules of glucose. That's why it has high affinity to enter into brain. And always remember, streptozotocin has high affinity for islets of Langerhans, and in islets of Langerhans we have particularly alpha, beta, gamma, and delta. All these cells are endocrine cells, which are very important in maintaining the homeostasis of particularly glucose. So what happens, this streptozotocin will try to destroy the beta cells, and with that it will cause diabetes. Simple. That's why streptozotocin is also very, very, very less commonly used in hospital. Okay, so it is available, it is given through IV route, and its T half is 15 minutes, and 10 to 20% of the dose is recovered intact in the urine. Okay, and one important point, streptozotocin is used in pancreatic cancer. Streptozotocin has no use in the hospital, but particularly in pancreatic cancer it is used in hospital, because in other cancers if it is used, it may aggravate or it may cause diabetes. Type 1 diabetes can be seen with overuse of streptozotocin. Okay, and yeah, that's it about today. I think we discussed about arsenic trioxide, very important compound, nitrosourea, and retinoids. Okay, with this, I'll quit the lecture. Thank you for watching. Please watch the previous videos and keep watching our lectures. Thank you all.